Hi, my name is Deborah Lee Matt, and I'm here to talk to you about SBIRT, Screening for Youth and Families. I do not claim to be a physician, and I'm not dispensing any medical advice. I'm just synthesizing available information from literature for the purpose of teaching the behavioral health professional about treating clients with substance use disorders. SBIRT was originally developed for the medical professional, the doctor's office, the nurse, the doctor, to help them screen their patients for early risk identification of substance use disorders. However, over time it has evolved, and we've been using SBIRT for about 10 years now. We can teach our police officers to use SBIRT. I've held classes and taught police officers to use SBIRT, as well as substance abuse counselors or those studying to be substance abuse counselors. I use a lot of the screening tools in my own practice. I find that they're effective and they work well in the population that we're talking about today, which is adolescent substance use disorders. So SBIRT is identified to detect early risk. This early detection tool helps prevent alcohol-related problems in patients and address them in the early stages. The screening questions and risk scales are developed through research and it's evidence-based practice. It's a quick, fast, and versatile tool, and it's the first tool to include the friends drinking pattern. So why do we screen for underage drinking? What's the importance of it? Alcohol is the current drug of choice amongst today's youth. It's often the first one tried. It's available to them through their parents, through their homes, through home parties. And over the course of adolescence, the proportion of kids that drink rose from 70 to 70% in 2010 to 2011. In 2017, we're seeing that still at a rapid incline. It's a risky behavior. Adolescent drinking often results in unintentional injuries, suicidal thoughts, aggressions, victimizations, unprotected sex, teen pregnancies, and other social problems. There is an increased risk of alcohol dependence later in life if kids start drinking at early ages. Heavy drinking in adolescence can result in long-lasting structural and functional changes for the adolescents that drink. So in medical practices, they start making use of SBIRT in clinics, and they basically screen the patients using the SBIRT tool. But we're going to use a couple of additional screening tools, the CRAFT and the AUDIT, which are approved SBIRT tools as a result of this training. And you can use them in the workforce as an addiction professional, along with your regular assessment on psychosocial tools. So medical practices rely on SBIRT when they're seeing patients for depression, anxiety, ADD, ADHD, vaping or cigarette use, accidents or injuries, sexually transmitted diseases, pregnancies, and changes in eating and sleeping patterns. As we know, adolescents have behavioral changes, so that's a given. But when you're looking for a sign of substance use disorders, we have to look for increased oppositional behaviors, significant mood changes, loss of interest in activities, changes of friends, a drop in grades, and a large number of excused absences. So there's a couple steps that we take. So step one is to ask 2 specific questions. And we really want to know, does the patient drink at all? So then step 2 is to guide the parent if they don't drink. And if they do drink, step 2 is then to assess the risk that the patient is in. So we move on to step 3 here. And step 3 is the advise and assist step. So we look at advising and assist. We have to assess the risk category. That's when we use the CRAFT or the audit tools, if they have answered positively to any of the SBIRT questions. And then step 4 is a follow-up appointment. So we meet with the client after the assessment and SBIRT assessment is completed for a follow-up session for continued support. And we engage in the motivational interviewing to help the client move towards change. So for ages 9 to 11, we're going to ask the friends question first. I'll tell you what the friends question is on the next slide. For ages 11 through 14, we're also going to ask the friends question first. For high school ages, we ask the patient questions first. So this is the friends question. We're going to ask the friends question first in ages 9 through 11 and ages 11 to 14. The friends question is this: do you have any friends who drank beer, wine, or any drink containing alcohol in the past year? The second question we're going to ask them is, how about you? In the past year, have you had any sips of wine, beer, or any other drink containing alcohol? So we're going to tally the results of those questions and then move on. But before we move on, we're going to talk about the high school age. It's important at the high school level to ask them the personal drinking question first. In the past year, how many days have you had more than a few sips of beer, wine, or any other drink containing alcohol? If your friends drink, how many drinks do they drink on a drinking occasion? We're going to see how much they drink and then 2, how much their friends drink. Now, neither the patient or the patient's friends drink. So what we're going to do first is we're going to praise them. We're going to thank them for the choice of not drinking. We're going to reinforce healthy choices with their parent present. And then we're going to elicit and reaffirm choices to stay alcohol-free. You know, what led up to your decision not to drink? Their answer could be, well, my parents taught me that drinking was bad for your health. So your response could be, I appreciate your willingness to stay true to your values in your family and not to drink and damage your health. And then we educate them about the dangers of alcohol anyway, to make sure that they know what binge drinking is and what kind of drinking is unsafe. And then we rescreen them the next visit or the next year. If the patient drinks but the friends drink, then we praise the patient's choice of not drinking around the friends. And we consider asking these questions. When do your friends drink? And what do you do instead? Or what do you do when you're drinking with them? How will you feel when others are drinking around you? Are you able to say no? If you're not able to say no, what makes you say yes? And then we review their responses and refusal skills about alcohol or other drugs. That might be a role play that we do with them in session that looks something like this. We could say to them, okay, so your friends drank all Friday night and you had 1 beer with them. Okay, next time, what could you do instead of drinking that beer? They could respond, well, I could bring my favorite soft drink to the party. And then you would say, how would you feel about saying to them that you don't want to drink and you want to drink your favorite soft drink instead? And that's where the refusal skill will come in. So you can model that with them. And then you always provide alcohol education about never riding in a vehicle or operating machinery with people who have drank. And we rescreen them at the next visit. So how many days did the patient drink in the last year? Why are we asking about a year's time? Maybe they don't know the answer, but we've seen in studies that low-risk patients drink under 5 drinks and high-risk patients drink 20 or more drinks in a year's time. So we have to assess the level of risk. Is it 5? Is it 20? Is it somewhere in between? So we need to know where our patient's drinking is. So it could be they drank 15 beers in the past year, and then we need to assess that level and what that quantity of drinking was and why they were drinking. So when we're working with adolescents, we always want to ask questions. The more questions we ask, the more comfortable they feel. So how often do you feel that you drink? They might not know. So we might say, do you drink 2 days a week? Do you drink 3 days a week? Do you drink 1 day a week? How many drinks do you have on one drinking occasion? Now, one drinking occasion is one night of drinking or one afternoon of drinking or one day of drinking. Do they drink alone? Do they drink with other people? Do they drink in school? Do they drink at other friends' houses? Are adults present and aware of them when they drink? Do they use any other substances when they drink? And if so, what are those substances? So what are the high risks that they take? Do they drive in vehicles? Do they go to parties? Do they break? Have they gotten in trouble with the law? Have they broken enterings? Have they left school? Have they disobeyed their parents? These are all things that we need to know as the addiction professional to further assess the risk. You're going to have a craft tool. And what the craft tool is something after we've asked the original expert questions and we've had a couple of yes responses, what we want to do is then we want to further assess them with a craft tool. Now, CRAFT is an acronym. It's used especially for adolescents and not adults. So C, the C in CRAFT stands for, have you driven in a car with someone, including yourself, who is high or using drugs and alcohol? The R stands for, do you use alcohol as a way to relax or other drugs? The A stands for, do you ever use alcohol or drugs when you are driving or when you are by yourself alone? F, do you ever forget things you did when you used alcohol or other drugs? And the other F, there's 2 F's in CRAFT, is does your family or friends ever tell you that you should cut down on your drinking? And T, have you ever gotten into trouble while using alcohol or drugs? An answer of yes to any one of these questions determines that there is a need for a further assessment. The audit. The audit is another screening tool that's used both in adolescents and adults that is also provided in the email that was sent to you. The 10-question audit, Alcohol Use Disorders Identification Test, is scored in adolescent populations from 14 to 18. The cutoff sum of 2 identifies any alcohol problem use, and the cutoff sum of 3 indicates alcohol use or dependence problems. So again, further screening, further meeting with this patient is required. We're going to talk about low-risk patients first and what to do to advise and assist. We're going to provide brief advice and recommend that they stop drinking. Now is the best time to stop drinking. Your brain is still developing. Alcohol can have an impact on a developing brain. For moderate risk patients, does the patient have alcohol-related problems? If no, provide concerned brief advice. If yes, conduct brief motivational interviewing to elicit a decision to change and ask parents to arrange for a follow-up visit within a month. We have to assess the highest risk patients, conduct brief motivational interviewing to elicit a commitment and decision to change. Ask parents if they know, and ask kids if the parents know. And we have to share with the parents when a release is signed. So we have to know the age of consent in our specific state. We consider making a follow-up for referrals. We arrange for a follow-up visit with them within a month or less than a month to get them through the process of changing and motivational interviews. The contingency plan can include discussing their perspectives about their current levels of use and partial successes, discussing a list of contingencies that may indicate problems exist and coping skills for each of these. We talk about harm reduction, what it means to cut back on drinking, and we collaborate a personal goal and action plan and develop an abstinence challenge. Follow-up and continued support, that's step 4. Was the patient able to sustain and meet all goals? So we have to know that the patient was able to meet all goals. And we work with them to develop if they can meet these goals. And we have to talk to them about ways they can meet these goals. Those are the objectives. So this is provided for you in your packet. So now we're going to talk about binge drinking. What is binge drinking in youth? For adults, having 5 or more drinks on one drinking occasion in the past 30 days constitutes binge drinking. The binge level of drinking for boys and girls varies. Ages 9 to 13, we see that having 3 or more drinks on one drinking occasion in the past 30 days is binge use. For ages 14 to 15, it's 4 for boys and 3 for girls. For ages 16 plus, it is 5 drinks for boys and 3 drinks for girls. Now we're going to talk a little bit about the effect of BAC. So BAC, we look at 0.02. 0.02, we have some loss of judgment, relaxation, slight body warmth, altered mood. We have a decline in visual functioning. At 0.05, we have exaggerated behaviors, may have the loss of small muscle coordination, focusing of the eyes, usually has a good feeling, lowered alertness, release of inhibition. For driving, we have reduced coordination, reduced ability to track moving objects. That's why you get this kind of a test when you're pulled over by the police. At 0.08, we look at muscle coordination becomes very poor, vision, reaction time, and hearing becomes poor. It's harder to detect danger. Judgment, self-control, reasoning, and memory are impaired. Concentration, short-term memory loss, speed control, reduced information. At 0.10, clear deterioration of reaction time. The ability to brake in time is impaired. And reduced ability to maintain lane position and brake appropriately. At 0.15, we have far less muscle control than normal. Vomiting may occur. Person has developed a tolerance for alcohol. There is a major loss of balance. Substantial impairment in vehicle control, inattention to driving tasks, and visual and auditory processing changes. So how to set up a youth expert interview? We review confidentiality laws for our state for minors with parents present or include duty to warn. We establish a private time for screening patients. We establish a time to review screening results with patients and parents if applicable. We decide how and when to honor commitments to change. We plan follow-up visits. We discuss referrals before they are made. We create an action plan for change, and we reassess that annually. So confidentiality and adolescence. When patients are minors, it's important to give your patients the assurance of confidential care. This is very important to them. So what we do, study shows that with confidential assurance, adolescents are open to being more truthful with a provider. So we have to talk to them about duty to warn. Inform adolescents that duty to warn parents and caregivers of certain information with the exception. And the exception is if what you tell me is that someone or somebody is hurting you physically or sexually, or if you are planning to hurt yourself or someone else, we will have to tell others and get them involved to keep you or that person safe. Motivational interviewing with adolescents. Motivational interviewing is a direct patient-centered style of counseling that helps clients explore their ambivalence towards change. It was developed by Miller and Rollinick in 1995. So the first key to motivational interviewing is to express empathy. We take a warm, non-judgmental stance. We listen. We reflect back emotions, ideas, concerns that the client is stating. We keep an open-minded approach. An example could be, I drank 5 beers and did some shrooms at the party. I was really out of it, says the client. The therapist could reply, it sounds like combining beer and mushrooms disorientated you for a while. The next step is develop discrepancy. We raise the client's awareness about their personal consequences of use. We ask how their goals, values, and beliefs could be hindered or compromised by substance use. The client could say, yeah, I really screwed up that night because I slept the next day and missed all my final exam. That affected my GPA big time. The therapist could say, it sounds like that night of a party cost you a lot with your grades and your schoolwork is important to you. Then for the resistant client, sometimes we have to roll with their level of resistance. So we have to acknowledge the patient's beliefs and feelings. We avoid lecturing or doubting or debating. We change gears if the patient shows resistance. Example, a client, yeah, but it's not a big deal. I passed with a C and the party was fun. And the therapist could say, you had fun despite the hit you took on the grade. Tell me more about why it was fun for you. So we're engaging a little bit more with the client, and then we could use some of the older motivational interviewing tools that we just went over to keep engaging with them through the process of change. We support their self-efficacy. We express confidence in the patient's ability to make a change, encouraging them to explore strengths and successes. An example of this is, what was fun was being around people instead of my studying. It was a good way for me to relax. I shouldn't have drank that much though. I realize I just got by and that's not good enough for my career choice. The therapist could reply, I'm encouraged to hear you say that your focus was off at that one time. Are there other ways you could have fun when you're doing finals besides drinking? Next, we develop individual goals and action plans with all our patients. We talk to them about an abstinence challenge. We ask permission to make a contract with them to determine the severity of the problem. So an abstinence challenge might look like, in the next week, how much do you see yourself drinking? They could say, well, I'm going to drink Friday night and I'm going to drink Saturday night. What would it look like for you to just drink one of those nights, and how much could you limit yourself to drinking? Then there's harm reduction, asking permission to negotiate a contract for drinking based on the patient's history, reducing the quantities over time progresses and limiting drinking to just a certain time of the week. For contingency, for more challenging patients who refuse to cut back, see treatment as a process, discuss perspectives about drinking and encourage their partial successes. Create a list of contingencies that indicate problems exist. Again, for the abstinence challenge, you want to use a harm reduction model until your client is ready to say, on May 5th, I'm going to stop drinking. This is the abstinence challenge that I have made up, so it's in your PowerPoint slides. Please Feel free to use it. It is not copyrighted material. Harm reduction. Chart a client's progress each visit. Use a readiness ruler. This is just using a simple ruler that you would find in your desk drawer and say on a scale of 1 to 12, with 12 being the highest, how ready are you to change based on what we talked about last session? You do it at the beginning of the session, and then you do the same thing at the end of the session, and then you use the ruler at the beginning of each session to chart a patient's progress. We encourage clients to reduce use and the amount of times they use in the upcoming week. We pick a quit date and we look for supports to help the client. Contingency. We always weigh the pros and cons of use. We make a values list. What's important to them? We provide education on the harmful use of substances on their health. We weigh their use against their values. In other words, if you used last Friday night and you got drunk and you missed studying, it looks like that went against your values. What values do you think that went against? They could say, well, it went against my values of being a good student. And then you could ask them, how could you be a better student next week? We're never telling them what to do. We're asking them what they think they can do better. So for all the 3 case studies, in order to get CASAC credit for this exam, what we do is we have a little handout that you need to do a complete SBIRT using the tools provided with a craft and audit. We identify the problem areas of each client. We complete motivational interviewing process, so you need to give me a little bit of a narrative about 2 of the motivational interviewing tools that you would use. Give me example conversations as outlined. Do individual goal and action plan for each client, and submit for final credentialing via email on the address provided. Or if this is a live class, we can do it in a live class. So thank you so much today for being a part of this presentation. And I hope that I have answered your questions about SBIRT. If you have any questions, feel free to email me in the address provided when you're submitting your homework, and have a blessed and happy day. Thank you.